Good afternoon, everybody, or good noon, as it might be. It is midday in Utah. It is 6 p.m. in Ireland, and it's 11 a.m. in California, where Dr. Fananapazir is. I'm delighted that he's our speaker for Grand Rounds today. He has done all the things. He's a professor of radiology at UC Davis, brief sojourn at the Mayo Clinic in Arizona, but then went back to his alma mater. His CV speaks for itself. I'm not going to bore you with reading that. However, what I do want to say about Dr. Fananapazir is that he is one of the best speakers I have ever heard. I always learn when I listen to him. And he has that singular skill of taking difficult subjects and breaking them down into little morsels of knowledge. What it's like a tasting menu. And when you're finished with the delicious bites of knowledge, you will leave replete and satisfied, and in this case, full of knowledge about renal transplant imaging. He's known in the inside circles as the fabulous Fananapazir. Maybe he's going to be a circus master, and one of his magic tricks in this talk is that he's going to turn me into Dr. Woodward, because due to the time change in Ireland, which happened last weekend, I'm actually about to get on a train to come back to America. So that is my introduction. Dr. Woodward will round up and moderate questions. Go, Dr. Fabulous Fananapazir.
Thank you so much. It is such an honor and privilege to be here. I have a lot of respect for the University of Utah, and I was actually really hoping to be able to make that to the University of Utah in person to be able to meet the residents and the faculty, but this will suffice for now, and hopefully I can come at some other time, assuming I don't give you all indigestion from this talk. Now, I do have to say, one of the things that really impresses me about University of Utah is the faculty that are there. Ann Kennedy, absolutely phenomenal person to get to know at conferences, such a delight, always creates a cheery atmosphere, and I've really enjoyed her mentorship during this process. I got to know Paula, I think, what was it, last year, a little bit better, and just such a good speaker, such a great educator, and truly impressive. And so I'm actually riding her coattails. I just got this book in. Oh, it's all blurry. But anyways,
put it in front of your face.
Like that?
Oh, in front of your face, because that's what it's zooming on. Tip it forward. Whatever.
Anyway, it's a textbook that was that I was asked to edit. And I'm following the footsteps of Paula Woodward because she was the one that edited before I did. And that becomes a phenomenally easy process because there's nothing to change. So I can just say, yes, all of those look good. Let's continue publishing it and take the credit for it. So, you know, you have some phenomenal faculty that are at University of Utah. I've also gotten to know Mariam Rizvani. So just a great group. So I'm going to share my screen right now. And let's see if this works. Fingers crossed. Do you see this?
We do.
Okay, perfect. So I was going to talk about the vascular imaging of kidney grafts. I got into kidney grafts when I started off as a faculty member at UC Davis. I'd done my fellowship at Duke, and I initially was not interested in research, but then when I was a fellow, I learned to really enjoy research because you could start asking questions that you were actually particularly intrigued to find out the information about, and that didn't exist in the literature. And so while I was at Duke, about to leave to UC Davis, I asked one of the faculty members, I said, what advice do you have about me going to UC Davis and doing research? And he said, well, find out what they do a lot of and make that the focus of your research. So when I arrived at UC Davis, for one of the years I was there, UC Davis was the #1 kidney transplant center in the country. Since then, I think Mayo Clinic has taken over, but UC Davis does a large number of kidney transplants, and they'll do a lot of the tougher kidney transplants. So you get to see some interesting techniques of being able to anastomose kidney grafts, but also some complications as well. And I was actually thinking of renaming this lecture to "There is no reason to settle for a non-contrast study." And let's go through the reasons why. So first of all, the only disclosure I have for this is I am going to be talking about an off-label agent called ferumoxytol. I'm not sure if you use that at University of Utah, but we use it here at UC Davis. We used it at Duke. And then when I was down at Mayo Clinic, we started introducing it there, and it got a lot of traction. So I will be talking about the use of ferumoxytol. So let's start a little bit more broadly. And I wanted to begin with something called the 17-year rule, which I think is fascinating. There's so much psychology that goes into medicine itself and how we practice and the way we practice and the way we interact with each other. And one of the things that is the study of a lot of investigation is the question of why does it take so long from something becoming shown by evidence in the literature to actually becoming something that we practice within our practice itself. And here's a particularly good article that I was reading. It says, when evidence says no, but doctors say yes, how often it is that we end up advising or practicing medicine in a way that is actually different from what the literature actually says. And one of the things that it goes into is, why is there such a latency? Why does it take physicians so long to be able to grab onto new information? And there's a number of reasons. One is the lack of knowledge about the current research. And I think that goes to say, we have tons of journals that we could access that all say large amounts of information. We have the access to societies to be able to go to and try and learn from those. But oftentimes it's overwhelming. And so sometimes when we're overwhelmed by the amount of knowledge out there, we end up not drinking from that fountain of knowledge. It's too much. So the lack of knowledge about current research is one of the reasons why there's this, quote, 17-year gap between when research suggests something and when we actually practice it as physicians. A second thing is uncertainty regarding how to interpret the studies. This is one that I think is particularly difficult, is when studies themselves defy intuition, when something is different than perhaps we would imagine it should be. And the thing that comes to mind for this is, I remember when I was in medical school, it was just coming out that beta blockers were actually useful for patients with heart failure. And before then, I remember in medical school learning, you do not give beta blockers to patients with heart failure. And then it ended up being that you actually should give beta blockers to people who have heart failure. And the justification behind not giving it was, well, it's a weakened heart. Why would you try to weaken it even more with giving a beta blocker? And then when the evidence eventually got absorbed and believed by physicians, there was an understanding that beta blockers allow the heart to be able to recover. So the intuition part of it is difficult because just because something logically makes sense, that isn't necessarily the way that things actually work. And so being humbled by these things, there are countless studies of things that we think one way is going to turn out, and then it ends up being something else. A fourth reason for our latency is risk aversion within our own setting. If we are dealing with contrast, for example, and we're talking to someone who is a nephrologist, and what they care about is the kidney, well, it may have a different spin than someone who's a radiologist who cares about the actual ability to be able to see what's going on. So people are going to see it from different perspectives. One of the things that I noticed, for example, is in procedures when we're doing a liver biopsy, if a patient, for example, is on aspirin, and they're doing that to minimize cardiovascular risk factors, then when we do a biopsy, should we hold off on the aspirin because it helps out our biopsy and perhaps decrease the risk of the biopsy? Or do we keep them on the aspirin because it minimizes the risks of cardiovascular events? And so oftentimes we're looking at our own particular setting to be able to define whether or not things are effective. And this is the toughest one, I think, is the availability heuristic. It's that if we happen to have had firsthand or even secondhand experience with something, then it makes us more averse um, to recommendations as far as taking in information. So for example, if we have learned through the literature that doing a liver biopsy, for example, in a patient with ascites is no more risky than doing it in a patient without ascites. Well, if we happen to have done a liver biopsy and have a bleed in a patient who had ascites, then maybe that availability heuristic kicks in and we say, okay, I'm never doing that again. And so there's a lot of reasons why, even though we have good data on things, things are not actually adopted by in practices. So this really comes into play in this discussion of use of contrast. Now, contrast agents are very useful to look at structures that are otherwise less conspicuous. And this is kind of the analogy I like to use. This is a Where's Waldo? We just had Halloween, and I found Waldo during Halloween. But in Where's Waldo, you have to try and find Waldo in a sea of individuals that look quite similar and backgrounds that look quite similar to what Waldo is actually wearing. And so it becomes much easier if you have Where's Waldo where everything else is black and white, and it really sticks out. And so this is really, as I understand, how contrast should be appreciated, is the ability to be able to rapidly see what's going on and identify things that otherwise may not be as obvious. And there are two main types of usages for contrast. We have the vascular uses where you can do intra-arterial injections or intravenous injections. And then there's the non-vascular luminal contrast evaluations, which we won't really focus on in this talk. So if we go to intravascular contrast, this becomes particularly challenging in patients who are kidney transplant recipients. And the reason that's the case is that oftentimes these are patients who have had kidneys that have failed, so they require a new kidney. And then they have a single kidney that's in there, and people want to make sure that that kidney is protected. And oftentimes when they're presenting for radiological images, it's not uncommon for them to be presenting because that particular kidney, the functioning of that kidney is in question. So here's an example of a case here where you can see the kidney in this coronal image, and there's a medial collection to the kidney graft. Now, oftentimes these represent, in the immediate postoperative settings, hematomas. And the location of the hematoma is really important. If it's lateral to the kidney graft, it's probably going to be okay. However, if it's medial to the kidney graft, then you have to start thinking about, is there something going on at the anastomosis that may be causing a problem? And so you can see when you say, okay, there's a medial transplant collection, let's give contrast to see what the anastomosis looks like. In this case here, there are multiple pseudoaneurysms. This patient has an anastomotic breakdown and eventually led to the kidney graft being lost. But you can imagine if we just had the non-contrast study and we decided not to give contrast, this could have been just diagnosed as a hematoma, whereas you give the contrast and you see there's pseudoaneurysms. This is a surgical emergency and needs to be revised. So contrast can make a massive difference in evaluating perianastomotic hematomas. Okay, let's look at this case right here. This is a patient who was about to receive a kidney transplant, so has renal failure, was on dialysis, and they decided, okay, let's do this non-contrast CT to see what's going on with the vasculature to see whether or not we can anastomose the vessels. Now, usually with a kidney transplant, you're anastomosing a kidney transplant to the internal or external, usually the external iliac arteries. And sometimes surgeons or nephrologists will just recommend doing a non-contrast CT. Now, you can see the difference in this case here where there's this non-con CT, there's a lot of atherosclerotic calcification involving the aorta and branch vessels. But if we decide to give contrast, and now we decide to take a look at it, we can see the aorta rapidly fill with thrombus. This is a patient with Leriche syndrome, was a smoker, ended up having complete occlusion of the abdominal aorta. This patient would not benefit very well from getting a kidney transplant to the external or internal iliac arteries just because of the inflow issue related to the kidney graft. So giving contrast can make a big difference, not only in evaluating the kidney transplant, but also in evaluating patients who may be receiving kidney transplants. Here's a case here. This is another usage of contrast. It's not just to look at the vasculature, but to evaluate for masses. Sometimes these patients are screened by ultrasound. Sometimes these patients are screened by CT. Sometimes they're not screened as far as looking for masses in kidneys. We know that patients who have renal dysfunction have an increased risk of developing renal cell carcinoma. So this patient had a CT. This in the inferior pole of the right kidney was questioned, is this a hyperdense cyst or is this a mass? And then this one over on the left was thought, well, it's probably a cyst. So this patient ended up getting a contrast enhanced ultrasound. And you can see when we added the contrast to this kidney, you can see that this lesion in the inferior pole, which we see on transverse image on the right, avidly takes up contrast. This ended up being a renal cell carcinoma. But we thought that since we have the contrast on board, why don't we just check out the other side of the kidney? Let's see what's going on here, make sure this is a cyst. This ended up being another solid renal mass. So this was a patient with renal cell carcinoma on both sides of the kidneys. It changed management. This patient needed bilateral nephrectomy prior to transplantation, because when you put a patient, when you put a graft into a patient, you have to put them on immunosuppression, and that can lead to rapid explosion of pre-existing tumors. Okay, let's take a look at this one here. This was a CT case I got. It was a patient who was a potential renal transplant recipient. Again, similarly, we're looking at the vasculature to see what's going on. But the other thing that we have to look at is, are there any masses that are in the kidney? And in this particular case, there's a subtle bulge within the left kidney. You can see that right there. That may need to be further evaluated. This patient ended up getting a contrast-enhanced ultrasound, and you can see this hypoechoic lesion right here. And if you follow it on the contrast-enhanced ultrasound, you'll see after the contrast starts going into the kidney, you can see it starting to come in. You can see this rapid uptake of contrast within this lesion here. This ended up being a patient with renal cell carcinoma, much more obvious on the contrast-enhanced study. This is another case. This is a case at Mayo where they decided to screen a patient to look for renal cell carcinoma by ultrasound. And the problem with ultrasound is that the sensitivity is and specificity are quite low for looking for renal cell carcinoma in this patient population. This patient fortuitously ended up arriving in the emergency department. They ended up getting a non-contrast CT. They didn't want to give contrast in this patient who had renal dysfunction, but it was astutely noted that there's this bulge within the right kidney. So they recommended that they give contrast to this patient. So this patient got a repeat with contrast. You can actually see that this bulge, which we thought might be a mass, ended up just being normal lobulation of the kidney. But check out what we found here. This ended up being a renal cell carcinoma fortuitously found in the patient who was a kidney donor on the the kidney transplant list. So this needed to come out before the patient received the kidney transplant. So when we're talking about the main agents for contrast, we have CT with iodinated agents. We have MRI predominantly with gadolinium agents, but I want to talk a little bit later about iron-based agents because I think that they're actually quite good. And then we have ultrasound with the microbubble contrast. Now, the big ones that people have issues over are the iodinated contrast and the gadolinium. So I thought we'd just go into the data a little bit to understand where these come from or where the hesitancy comes from. Now, we know that when we're dealing with pharmaceuticals, the benefit should outweigh the risks associated with it. We know that people have been denied getting contrast because of concern of reduced kidney function, both in iodinated contrast and gadolinium-based contrast. And that's because of the harm that is felt to arise either from iodinated contrast worsening the kidney function or gadolinium contrast agents giving nephrogenic systemic fibrosis. But the other thing to keep in mind is this indirect harm that can be related to a delayed diagnosis or a misdiagnosis. So that's something I think that we need to keep in mind as well. And then we have to have a good understanding of what is the true risk associated with these contrast agents. Now, if we look at iodinated contrast agents, you can kind of divide up the way we've been thinking about contrast agents with iodine into three different eras. One is the 1954 to 2008, where iodinated contrast or contrast-induced nephropathy was unquestioned as a leading cause of renal failure in patients who were hospitalized. Fast forward to 2008 to 2013, which was quite an exciting time, is there was some question about what role iodinated-based contrast actually plays in kidney dysfunction. What is the actual risk associated with it? People started questioning that. And then we have 2013 to present, where we found that iodine-based contrast agents are much less nephrotoxic than thought and may actually not be nephrotoxic at all. So let's go back into the original paper that described iodinated contrast agents causing problems. This is a patient who had acute anuria, who had intravenous pyelography, and this is a patient who had multiple myeloma. So they happened to, after they got the IVP, in a patient with multiple myeloma, have anuria. And so they postulated here, it says, at any rate, Holman's and our observations call upon us to include myelomatosis as an etiological possibility in cases of acute anuria, as well as to be cautious of using intravenous pyelography in patients where there is a possibility of the presence of myelomatosis. So this is where it comes from. It comes from a case report from 1954, where it posited that it may, in the setting of multiple myeloma, contribute to acute anuria. So people started looking into this and started thinking, okay, well, how much incidence of nephropathy is caused by contrast? And when people looked into it, they estimated it to be around 2% in the general population. But in specific populations, like those who had renal impairment or those patients with diabetes, there was up to a 50% risk of contrast-induced nephropathy. And there were a whole bunch of reasons that were given. The pathophysiology wasn't really well understood as to why it would cause dysfunction, but there were a number of different hypotheses that were given. So there are a few problems with these, though. One is that there are various definitions that were given for acute kidney injury. Nobody really agreed on how do you define acute kidney injury, so it made it difficult to compare studies. The other thing that made comparison of studies difficult was the variety of contrast agents that were used. Up to the late 1960s, there were high osmolarity contrast agents used. And then there were ionic monomers and then non-ionic monomers and then non-ionic dimers. So all of these different contrast agents probably behave differently, but they were all lumped together into contrast-induced nephropathy. The other thing that was problematic is that almost all of the studies that looked at contrast-induced nephropathy were arterial studies. Most of them were coronary angiographies. And so they weren't really looking at the intravenous injection of contrast, which is what we do mostly from a diagnostic standpoint. Only 40 out of the 3,081, or 1.3% of the studies, actually come from intravenous study data. And even when we look at those studies, 38 out of the 40 studies of intravenous contrast was not performed with a control group. When you look at the ones that had a control group, there were only 2 studies that had a control group during this period of time, and both of them failed to demonstrate an association between contrast and acute kidney injury. But these were obviously confounded by selection bias. There were certain people who would get contrast and certain people who wouldn't get contrast, and those were quite different patient populations. Okay, so 2008 to 2013 is when people started questioning and wanting to quantify, well, what is the risk of acute kidney injury from giving contrast? And this is where the definition started to shift from contrast-induced nephropathy to contrast-associated acute kidney injury. When we look at the data behind this, it looks like if you have a GFR greater than 60, you have a 5% risk, all the way down to a GFR less than 30 is a 30% risk. So people were trying to figure out, okay, this is contrast-associated acute kidney injury. How much is actually caused by the contrast itself? And this is where some of the studies looked into it. They looked at one study where they took hospitalized patients with no contrast administration. So that was 32,161 patients they were hospitalized. And they looked at and pretended as if, okay, let's pretend like they got contrast at a particular point when they really didn't. What they found is that their baseline rate of developing acute kidney injury mirrored what people were seeing as far as contrast-induced nephropathy. So even if you pretended like you gave it, the rate of acute kidney injury was the same as what we were seeing from what was quoted as contrast-induced nephropathy. There was another study that had 11,588 patients who underwent a non-contrast CT and a contrast-enhanced CT. There was no difference in acute kidney injury in patients who had CKD stages 1 through 3. And there was a slight increase in acute kidney injury in patients with CKD 4 and 5. So a 3.4% increased risk between the two groups. But again, there's selection bias. The people who got contrast and the people who didn't get contrast were not randomly assigned. They were completely different patient populations. So then we start fast forwarding into 2013 to present, and there are a number of studies that came out with much better study designs. One of them is propensity matching, where you take people who have very similar characteristics in a retrospective study. You match them up with very similar characteristics of things that you think may be confounding variables, and you start matching them up to patients who didn't or did receive contrast. And so in this particular study, they had 17,652 patients who were matched 1-to-1. They found no difference with a GFR greater than 30. And if you had an eGFR less than 30, it looked like there was a 17% risk, but it was underpowered. There were not a lot of patients in that category to be able to match up. Now, McDonald et al. Also did a study similar where they had 44,934 patients, so a much larger group, and they didn't find any differences in any of the GFR categories. There was another study that came out more recently in JAMA that I thought was really interesting. It was something called fuzzy regression analysis, which I'm not a statistician. I don't claim to know these things, but I think it was quite interesting. They took people who had very similar characteristics, but if they had a threshold value that just put them over or just under, it changed whether or not or how they were managed. And so what they ended up doing was D-dimer results. And if they were just qualified to get a PE study, they'd be in one group. And if they just missed it for being qualified for it, they would go in another group. And so the patients were actually quite evenly matched up because they were picking, a point in the D-dimer levels where there wasn't a whole lot of difference between them. And so they ended up having 156,000 patients who had the two different studies, and they found no difference in the rate of acute kidney injury following contrast injection. And so what we ended up finding out is that contrast-induced acute kidney injury, so not contrast-associated acute kidney injury, but actually what does contrast cause as far as acute kidney injury? All of the studies agree that if you have a GFR greater than 45, you have a 0% chance of a 0% increased likelihood of acute kidney injury. 30 to 44, 0 to 2%, just because we don't have as many patients in that group. And the less than 30, that's the really underpowered group, is anywhere from a 0 to 17% chance. So it's possible that there's no increased likelihood, or it's possible that there's a 17% increased likelihood of getting acute kidney injury. And so a joint statement came out by the ACR and the National Kidney Foundation on intravenous contrast usage on CT, which basically says similar things of we can relax as far as certain GFR levels. So what about kidney graft recipients? Well, there haven't been as many studies looking at the risk associated with them. There was one study where it found maybe a 3% rate of contrast associated acute kidney injury. Again, not contrast-induced acute kidney injury, but contrast-associated. None of the patients that ended up having intravenous contrast went on to have dialysis or had graft loss associated with it. There was another study where it was 124 patients, which had a 5.6% rate. Again, none required dialysis or had graft loss. And this led to the Contrast Medium Safety Committee at the European Society of Urogeneral Radiology saying there is insufficient evidence to substantiate a higher incidence of contrast-induced nephropathy in kidney transplant recipients than in the non-transplant population. So I think overall, we can be much more liberal about the use of iodinated contrast in patients with kidney grafts. And then it said here in their joint statement, single kidney, which includes transplant, should be managed similarly to patients with normal kidney volume. Okay, let's quickly go through gadolinium. Gadolinium is strongly paramagnetic, which makes it a great MR contrast agent. The problem is that free gadolinium is toxic. That's why it's attached to a ligand. And you have two types of ligands. You have the linear agents, where you can see the gadolinium is kind of more loosely associated with it. And then you have the macrocyclics where it's surrounding the gadolinium. You also have a group 3, which are more linear agents, but they also happen to be excreted rather than through the kidneys. They also have hepatobiliary excretion as well. So they have another way of getting their contrast out. So gadolinium pre-2006 was often used as a substitute for iodinated contrast since there was a concern for that in patients with CKD 4 and 5. The doses were pretty high. When you look at the amount of contrast that would be delivered, sometimes people would do angiograms, conventional angiograms, so they would just inject gadolinium. And so the amount of contrast that people would give was quite high. In 2006, the first linked case with gadolinium and nephrogenic systemic fibrosis was suggested. Risk factors were looked into. The increased dose was an important risk factor. Acute kidney injury or those with CKD 4 and 5. And group 1 agents, the ones that were the linear agents, were the ones that were associated or linked with nephrogenic systemic fibrosis. So in 2010, a black box warning went out and it changed the way that we gave contrast to patients with chronic kidney disease or acute kidney injury. In 2018 until present, the landscape has actually changed quite a lot. The cases now are down to single digits per year. We don't have a lot of cases of NSF. If you compare that with 2012, there were 1,600 cases. And so some of the reasons that are postulated are increased regulations, decreased utilization of group 1 agents. Hardly anyone uses group 1 agents anymore, and also changes in the clinical practice guidelines. Now, in hindsight, we're looking and reviewing the group 2 agents. Those are the macrocyclic agents. And in 4,931 administrations in patients who had CKD 4 or 5, there were no cases of NSF identified. If you look at patients with stage 5 CKD alone, there are no cases out of 1,848. And when we look at EOVIS, which is a linear but also has hepatobiliary excretion, there have been no confirmed cases of NSF, but you can see that the number of patients that receive EOVIS is way less. And so our confidence interval is going to be much wider in that case. But there were no cases out of 85. And so this has led to a joint statement again by the ACR and National Kidney Foundation on gadolinium-based agents, where it essentially says that there are hardly any cases in which the risk is going to outweigh the benefit, and to strongly consider the use of gadolinium-based contrasts in almost all clinical settings. Okay, so let's move on to our other contrast agent that we have available before we start moving to ultrasound. And this one is called ferromoxetol. Ferromoxetol is an iron oxide agent, so it actually doesn't have gadolinium. And if you take a look at the bottle, it looks black. I mean, it looks like you're giving something medieval when you give ferriheme, but it's an iron-based agent. It was initially investigated as a contrast agent, but they found it easy to market it more easily as an iron replacement agent for patients who have kidney dysfunction. So patients with kidney dysfunction oftentimes have iron issues, and you can replete their iron using ferriheme. So it happens to be a great off-label contrast agent. And one of the reasons why is that the half-life of ferromoxetol is about 15 hours. So it's also a blood pool agent, so you don't get it going into the parenchyma and being excreted out of the urinary tract or anything like that. And when you have really long acquisition times, or the ability to do long acquisition times, you can get some really beautiful high-resolution MR angiographic images as a result. And you can scan a patient, and 2 days later, you can rescan them without having to re-inject them with contrast. So we were sometimes doing this for patients who had pancreas transplants, who we wanted to see their venous thrombosis to see whether it was extending. We would just bring them back a couple days later, rescan them without having to re-inject them. So here's an example here of a pancreas transplant. You can see this is with ferromoxetol. You can see the high-resolution images that are associated with it. It allows us to be able to quite clearly see the vasculature associated with the kidney transplant on the left and the pancreas transplant on the right. And you can see quite nicely, here's the pancreas graft with the orange arrow. And then you can see the arterial graft right there, which is nice and patent. And then you can see the thrombosed venous component to the pancreas graft. So you can get some really nice, beautiful images. Here's another case that we were doing on a liver transplant. Remember, this is a blood pool agent, so it only stays within the blood pool, but you can see beautiful angiographic evaluation. You can see these large splenorenal varices that ended up being quite symptomatic in this particular patient. But the other thing that kind of caught our eye as well is the amount of contrast that was actually in the duodenum. And so this patient was actually able to be diagnosed as having a GI bleed that wasn't detected clinically until about 24 hours later. Now, these can be used for many other things. You can use them for provocative maneuvers when you're looking for like thoracic outlet syndrome, but you can see it's not a bad pulmonary embolism examination as well. You know, push comes to shove, they're hesitant about using iodinated contrast. Ferromoxetol is not a bad agent to look for pulmonary embolism. And we've used them quite a lot in the renal transplant patients. We've done some investigations into their utility. And we use these primarily to look at the transplant vasculature to look for transplant renal artery stenosis. And I think that's really where ferriheme plays a big role in the vascular evaluation of renal transplants. Now, as we know, transplant renal artery stenosis is the most common vascular complication associated with kidney grafts and does lead to an increased graft loss and patient death. We know that if patients are treated with endovascular intervention, they do quite well. And in fact, if they're intervened on, they can have similar outcomes to patients who never had transplant renal artery stenosis. So it's good to have a good screening program to look for transplant renal artery stenosis by ultrasound. But MR can play a nice role in being able to depict what that stenosis actually looks like. So before we were using ferromoxetol, if you had clinical suspicion for transplant renal artery stenosis, which can have a variety of presentations, we would go to ultrasound. If the ultrasound was negative, it would be biopsied because it would be assumed to be a parenchymal issue. And if it was positive, they would go under angiography. But the interventional radiologists were kind of interested at trying to figure out how to decrease the number of angiograms that were being done, because there were a lot of them were being done that ended up being negative. And so this is where we kind of saw, hey, is there a role to, one, improve ultrasound, and two, to be able to inject MR with ferromoxetol into the algorithm itself. Now, ultrasound is a great tool, very, very powerful for assessing kidney grafts. The problem is that it is operator dependent, and there's not a lot of uniformity sometimes in how studies are culled as far as transplant renal artery stenosis is concerned. And part of that is there's a variety of different ways in which transplant renal artery stenosis presents by ultrasound. You can have parvus tardus waveforms. You can have turbulent waveforms. You can have increased renal artery velocity. Is it the ratio of the renal artery velocity to the external iliac velocity? Is it resistive index? What are the things that are important in assessing for transplant renal artery stenosis? And how do we end up suggesting which ones may be more important than others? And one of the things that the transplant nephrologists were talking to me about is they said, well, with our ultrasound reports, we appreciate them, but we kind of just want to know which direction we want to go in. They wanted to think more in terms of, is it suggested that it's there, or is it not suggested it's there? And so we tried to develop a way of being able to assess for transplant renal artery stenosis based off of measurable factors. What we ended up finding out in our internal data was that there were only 3 things that were really important, major factors for transplant renal artery stenosis. One of them was, is the velocity greater than 300 centimeters per second? So if that was true, that would be one major risk factor. The other thing we found was that if you had turbulent waveform, and we'll get to what that looks like, but if you have spectral broadening within the renal artery, that suggests that if you have turbulence, there must be something that's causing that turbulence. That ended up being a major risk factor. And the other thing that ended up being a major risk factor was, do you have delayed upstroke, which was defined as greater than 0.1 seconds to the systolic peak. So those are the 3 things. If you had none of those risk factors, there was no chance of having a stenosis. If you had all 3 risk factors, you ended up having a 99% chance of a transplant renal artery stenosis. But interestingly, if you just had one of those, if we just, for example, saw turbulent waveforms, or just saw an increased velocity, or just saw delayed upstroke in the intraparenchymal artery, then that had a 33% chance of a stenosis. So it's possible to have transplant renal artery stenosis and actually quite a high, a 90% chance of a stenosis, even if you don't have an elevated velocity. So that led us to kind of look in terms of, well, there are 3 types of ways in which we can report transplant renal artery stenosis. Is either there's no chance, don't worry about it, or extremely high chance, and it's probably diagnostic, or there's somewhere in between where we just don't know. We can't be confident in how we assess things. And this is where we kind of injected pheromoxetol MR into the algorithm, is that if the ultrasound was positive or equivocal, before undergoing angiography, they would get a pheromoxetol MRA. So let's look at a few examples here. Here's an example of a spectral Doppler image. You can see that the velocity is 800 plus centimeters per second. You can also actually see this activity down here whenever systole is happening. This is the soft tissue vibration that's going on within, because of the transplant renal artery stenosis. It causes vibration. Apparently, if you put a stethoscope over that, you can hear a bruit. This is the ultrasound bruit sign right down here. You can see in the distal renal artery, that spectrum, which was nice and thin here, the range of velocities was a tight range of velocities here. This is spectral narrowing, now moves to spectral broadening, where there's so many different velocities that things are moving on. It's choppy. This is what we're talking about by spectral broadening. And then when you look at the intraparenchymal artery, the time it takes to get to peak was 0.1 seconds or greater. This would be a very classic look for transplant renal artery stenosis, incorporating all 3 of the criteria that we had mentioned before. So we tried a few things out. We first of all tried the unenhanced MRA just to see what it looked like. It doesn't do very well with turns of the vessel. Here you can see the MRA with pheromoxetol. You can see this narrowing right at the proximal portion of the transplanted renal artery. And then you can see the comparison angiography right beside it. And one of the things that we noticed was that the MR angiography with pheromoxetol was a very nice depiction of what it ended up being like angiographically. Here's another example here of, we had a very high risk of stenosis. We ended up doing an MRA beforehand. You can see the stenosis right here of the transplanted renal artery, which is depicted nicely on the angiographic image. However, we also noted on the MRA that there was a dissection flap in the external iliac artery, which you can also see on the angiogram, but you can see that the interventional radiologists ended up, because they knew about that flap, they came from the contralateral side to do the injection. So MR can be useful not just in the setting of questionable transplant renal artery stenosis, but can actually change management in cases where there's a known stenosis. And so in this patient here, this is what we do at UC Davis. They got an MRI with ferromoxetol. We're able to, utilizing the software, actually figure out, well, what are the table positioning that needs to be there? The interventional radiologist, when they do their first run, can also match that to be able to give a nice image on their first run. So here are a few cases. Here's one where there was no elevated velocity. This is the distal artery and the intraparenchymal. As you will notice, though, there is spectral broadening. This is nice and filled in. It's actually filled in here as well. And then you can see that there is a delay in the upstroke. It's taking more than 0.1 seconds to get there. So we suggested that maybe this might have transplant renal artery stenosis. This was actually the first case that we decided to do an MR with ferromoxetol at Mayo Clinic. There was some disbelief to this, but fortunately, we were able to diagnose transplant renal artery stenosis, and sure enough, this patient had a distal transplant renal artery stenosis that was missed on the ultrasound. Here's another one here. They're calling this the proximal or the anastomotic renal artery. You can see there's actually a delay in upstroke here. There's spectral broadening, so it has 2 out of the 3 criteria, but we can never get the velocity to be increased. What happened was that this ended up being mislabeled as the proximal portion of the transplanted renal artery. This patient had a kink, had a transplant renal artery stenosis at the kink, which was diagnosed based off of MR angiography. Here's a case here where you have elevated velocity. You can see the whitening of the inside. This is the spectral broadening, so 2 of the 3 criteria. And then finally, here's another one here where you can see there looks like there's a delay in the upstroke. It's taking more than 0.1 seconds, so this would be high risk for transplant renal artery stenosis. Here's another example where we got an MR, and then you can see the conventional angiography and how they compare with each other. So there are a bunch of other applications to ferromoxetol. One of them is that we're able to see the venous side to things where normally we haven't been able to see it. Here, this patient ended up having a venous stenosis right above the grafts that led to elevated resistive indices. And we can see on the venogram that was performed, the contrast gets injected through the iliac vein, and you can see this tight narrowing and the development of these collateral vessels in the pelvis. So the venous side of things we haven't typically been able to see, but it allows us to see some very interesting things. Here, this is a case where there's a transplant renal artery stenosis. There's a long segment of narrowing right here, but check out the vein. The vein is supposed to look like this. You're supposed to have the vein kind of overlapping where the artery is and look like this. Instead, this vein becomes this conglomeration of veins down here. And what it looks like happened is that the normal connection ended up getting severed, and this patient developed collateral vessels. And sure enough, when we did an angiogram, I asked the interventional radiologist, hey, can you just run it out a little bit longer? And you can see, rather than having a vein going back to your external iliac vein, this patient had thrombosis or occlusion of the transplanted renal vein and ended up developing a strong set of collateral vessels that made its way to other veins within the body. Now, the other thing, as far as kidney transplants is concerned, one of the important things that that sometimes is neglected is really the assessment of the cortex of the kidney itself. That's really important. And it's not enough just to see some flow within the kidney. We really have to make sure that the whole entire kidney is perfused. And we have different ways of doing that. Color, power Doppler have historically been good ways to do that. I love B-flow, which is a non-Doppler image way to assess for vasculature. It uses the grayscale images, and so your resolution ends up being much better. The other thing that's really good about it is that there aren't a lot of parameters to be able to change in B-flow. And so it's not operator dependent in the same way that Doppler is. Doppler, one can make it look like there's flow when there's not, and it can make it look like there's no flow when there actually is flow. B-flow, there's not a lot that you can change within the parameters, so you get more consistent evaluation of parenchymal vascularity. The other option, though, that you have to be able to assess for vascularity or for perfusion within the small vessels is contrast-enhanced ultrasound. And I think this is quite an underutilized technique in transplant evaluation. You can do a few things with it. One of them, you can get time intensity curves from cortical perfusion and potentially see if there's dysfunction associated with the kidney based on its time to perfusion. That's something that's not clinically done, but is something that's in investigation. But you can actually use contrast just to be sure in certain cases and certain diagnoses. So this is a patient who actually had an arterial thrombus. They had 2 kidney transplants. This was a pediatric en bloc kidney transplant that was placed. Ultrasound imaging was suggestive of a thrombosis. We just gave contrast just to make absolutely sure. This patient ended up being taken to the operating room right away. They tried reperfusing, and you can see that the kidneys after the thrombectomy ended up getting some perfusion, but they also had some areas of infarcts afterwards. So at least we were able to get a baseline understanding of what the perfusion looked like after they received, after the thrombectomy. And then the final thing that I think is really useful for contrast-enhanced ultrasound is looking for acute cortical necrosis, which I think is a very underdiagnosed disease in patients with kidney grafts, where you get perfusion of the medullary portions and the central portions of the kidney, but the outer cortex can be infarcted. And so sometimes, and then this is actually an example of a case where this is read as normal perfusion, even though when you look at the cortex itself was not really perfused. Looking here on the B-flow images, again, this was called perfused kidney. I would argue that the outer portion of it is not perfused, but these can be tricky because in patients with acute cortical necrosis, the resistive indices can be normal. And that's primarily because the blood shunts away from the cortex back through the kidney and can produce normal resistive indices when the blood is being shunted. But these become not diagnostic dilemmas if we say, okay, there's questionable perfusion, like in this case here, you can see the perfusion does not look great. We're not getting great perfusion out to the cortex. This patient ended up getting a contrast-enhanced ultrasound, and you can see there's complete absence in most portions of the kidney transplant of contrast within them. This is acute cortical necrosis in the renal graft itself. And so this is something that really benefits from getting contrast. So if you have a case where you're just worried about the perfusion, giving contrast can be helpful just to be able to say whether or not it's because the patient has acute tubular injury or whether it's caused by acute cortical necrosis. So that's the end of the talk. Really, this is just a summary slide here. I think the main point, though, is that contrast, there's very little time in which contrast should not be given. Iodinated contrast, as we talked about, is relatively safe for patients with EGFR greater than 30, and probably okay for patients with an EGFR less than 30. We know that gadolinium contrast is relatively safe regardless of the EGFR because we're using probably the macrocyclic type gadolinium agents. If we're looking for renal mass evaluations, contrast-enhanced ultrasound plays a very important role. Contrast-enhanced ultrasound is better at detecting enhancement than CT or MRI is. And so if you have the ability to look by ultrasound, doing contrast-enhanced ultrasound can be quite helpful. And then finally, when we're looking at vascular evaluation, contrast-enhanced CT, contrast-enhanced MRI are all possibilities. I do personally really like FSAR. I don't have stake in the company, but I think is a very useful tool at being able to look at the vasculature. You can give it to patients with a GFR of 0 without any concerns for nephrogenic systemic fibrosis or concerns about their kidney function. And then finally, it's not bad to have an additional imaging modality in patients with ultrasound, that when we're doing ultrasound, being able to assess, okay, what is the risk of of transplant renal artery stenosis? Is it none? Is it high? Or is it somewhere in between? And I think that somewhere in between is not a bad time to be able to think about, are there things we can do either with CT or MRI to be able to evaluate for transplant renal artery stenosis? So that's really it. I thank you so much for your attention. I really appreciated the opportunity, and hopefully I'll be able to come in person at some point.
Ghaneh, thank you
Hey.
so much. And to continue with Anne's theme, I just had a 10-course meal here. I just, next time, if I could only ask for wine pairings to accompany, it would be even better. So that was incredible. Thank you so much for that. Roy, are we able to unmute people, or do they have to text through the chat for questions?
Yeah, there's a Q&A box at the bottom. That's where they can type in their question. Unfortunately, it's a Zoom setting that I cannot unmute everyone.
That's unfortunate, because I would love to get a discussion going with Glenn and the other people in the abdomen section regarding ferumoxytol. And boy, I thought those images were exquisite.
Yeah.
And we have very little experience with that.
Yeah, so we we're able to get down to about 1 millimeter in resolution for looking at vasculature. So when we're thinking about really small vessels, that's a great time to look at it. And the thing that's really nice about it is, even if you don't get great images, you can just take another set of great images. They do take about, the high resolution images that we take here at UC Davis take about anywhere between 5 and 10 minutes to acquire those images. So it does take a while. But the nice thing is, if they don't turn out really well, you haven't lost anything. You can just reacquire them. Even if the patient needs to go upstairs and then, needs to be taken care of, you can always bring them back within probably about 48 to 72 hours and then just redo those images without having to re-inject.
Mark Clore's doing some real interesting work with ferumoxytol and placenta cretus studies.
Yeah.
So it has some really interesting vascular properties.
Yeah.
So I found that fascinating. I also learned a new word. I did not know the word heuristic. So essentially, that's practicing according to your last worst case. Is that kind of what that is?
It's kind of like the scout images, right? Like we see the scout images, we don't look at them, and then someone brings to our attention that on the scout image you could actually see X, Y, and Z. And so for the next, week or so, I'll be looking at all the scout images and then eventually tail off.
Then you
that's
don't look at them anymore. Right.
That's
Shame
how I
on
understand
you.
heuristic.
Always look at the scout image.
Always look at the scout.
Okay, and I also found it fascinating, the 17-year rule. I hadn't that, which as you were giving us some of the data, and I was looking when it was published, when it's finally going to be accepted, we can give contrast without concern, will be roughly 2032 to 2037.
That's correct.
So I won't be practicing at that time, but hopefully everybody out there will give contrast without issue.
Yeah, I think it's interesting. Like, to me, that's one of the fascinating aspects, is the psychological adoption of certain things. It takes a while. And part of it is, I think it started out in radiology, where radiologists were really questioning, is this important to withhold contrast? Because I think our bias was, we would love to give contrast more liberally. And so we were able to start looking at that. And then it was interesting. It came out initially in the radiology literature, and then it started going out into the emergency department literature, and then eventually came into the nephrology literature and some of the other specialties out there. And so, yeah, I think it's taken a while, but I think we're moving in that direction, and 2032 is not too far away.
So Glenn has put questions into, can you see the Q&A box?
I can.
There, and I'm sorry Glenn can't speak because this is his area of expertise. And if everybody else can see the Q&A box, he's asking about some T2 shortening and how that affects your images. And so, Ghaneh, I'll just let you address that.
Oh, I can't see those ones. Let me see.
Oh, you can't. It's
Let me
in the
see.
Q&A. So it says, SPIOs have traditionally been used for T2-star shortening and totally clobber the images. I'm
Yep.
assuming you're using a much lower dose and use the T1 shortening effect. This would also make your injection more feasible. With the
Yeah.
SPIOs in the past, do you inject more slowly over a half hour and then wait 2 hours before imaging?
Yeah, good question. So when we were initially looking at Farahim when I was a fellow at Duke, it was one of the studies we looked at was we were seeing that when we would inject it, the T2 shortening would so overwhelm the images that you ended up looking like you had clots throughout the abdomen and pelvis. And so you would see what looked like a portal venous thrombus, but then you would allow it to mix and then it would clear out and you would see, no, it was just because there was too much Farahim. And so based off of that data that we had, we were able to dilute. What we ended up is diluting the Farahim more. We would still inject it fairly, you can inject it over a 10-minute time period. And then we would start doing the imaging itself. So we decreased the concentration, and then we also increased the amount of time that it would take to inject a patient. But theoretically, you could inject them even on the floor. You don't have to use up MR scanner time. You can inject them on the floor and then bring them down afterwards, and then you can start imaging them at that point. I've always thought it would be a great contrast agent to be able to look for GI bleeds, because at that point, it doesn't matter when they're having that event, you can still bring them down and see where it is anatomically that it could potentially be coming from. And given that you have 2-3 days to image it, you could potentially inject them on the floor. And then when they have an event, but they're stabilized, bring them down to be able to localize where the bleeding comes from.
Okay. Then he asked, are your post-Farahim images conventional T1 weighted, or are you doing some sort of susceptibility imaging, mapping?
No, they're just conventional T1 images.
Okay.
Yeah.
All right. Well, this was awesome. Thank you for the delicious meal you served. We have a lot to chew on to keep the metaphor going. So thank you, Ghaneh. It was delightful.
Thank you. Thank you all.
Okay.
Have a good one.